Okay.
Go
And
ahead.
can you
Yes.
see the presentation?
We can, yes. Yeah.
Okay. So the topic of my talk is testing times, fighting COVID-19 deaths in India. It is more of a very, very simple and broad work in which we just look at what is happening to death-related measures at the state level in India. And because it's actually quite early in the day to work on this, so maybe this talk will probably raise more questions than give answers. So anyway, so I have, so this work is actually co-authored with Tirtha Chatterjee, my colleague at the Center for Development Studies. So, one second. Yeah. So as we know, the COVID-19 outbreak is an unprecedented shock to the global economy, with it being more severe than the previous outbreaks of MERS, SARS, HIV, and so on. Since the first case that came in China in December 2019, the virus has spread at an alarming rate, almost infecting 4.2 million people across 220 countries. Obviously, the World Health Organization announced it as a pandemic long back. And with no vaccine or treatment, what is being said is testing and social distancing are the golden rules. As a result of this, what we've seen is that a lot of countries are responding with wide set of preventive measures ranging from travel restrictions, stay-at-home orders to a complete lockdown. And in fact, if we look at the numbers, as of April 28th, almost one-third of the world population was under some form of lockdown. And almost half of the world population was under some sort of a stay-at-home order. Obviously, what we've seen is that this pandemic has led to an economic footfall, with economic activity coming to a complete stall, as a result of which both supply and demand crises are in place, affecting lives and livelihood. India recorded its first COVID-19 case on January 30th. The government responded with a 3-week lockdown on March 25th, which was extended twice later on. And as we know, India scored pretty high on the government response stringency index, the index which was developed by the University of Oxford, which we were discussing a little while earlier. And what this lockdown has sort of revealed is mismanagement on part of the central as well as the state governments, in terms of various events like an unplanned exodus of millions of migrant workers from cities trying to go back to their home villages or home states, swift communal turn due to a huge spike in the number of cases after a religious gathering in mid-March in Delhi, chaos in acquiring rapid testing kits, soaring unemployment, joblessness, and so on. The main reason for this lockdown, because we did not have a vaccine or a cure, was to actually flatten the curve. But what we've seen is that the cases and deaths related to COVID-19 have been rising in the country. As we talk now, we have almost 1,000 cases with close to 2,500 deaths. There are two features which stand out when we talk about COVID-19 related cases and deaths. One is there is a lot of spatial variation in cases and deaths across states in India. And second is that there is no uniform pattern between cases and deaths across India. What I mean is that if we look at the spatial pattern for cases across India and the spatial pattern for deaths across India, there's not really a sort of uniform pattern that we observe. For instance, as on May 3rd, if we look at the number of cases in Delhi, it was close to 4,100, with number of deaths being only at 46. On the other hand, Madhya Pradesh on the same date had close to 2,500 cases, with a huge number of 150 deaths, approximately 150 deaths. So what we're trying to do over here is we are trying to capture severity of this ongoing pandemic. And of course, there are many measures available for this: incidence rate, transmission rate, or fatality rate. There are several studies which have focused on spread of the disease incidence, but there's not much academic attention given to fatality. So what we are trying to do against this objective is to not estimate, but actually just compute fatality rates for COVID-19 in India for April 2020. And when we do that, we look at two important features. One is what is the spatial and intertemporal pattern at the state level using data from 20 major states. And second is what are the possible or potential factors that drive this variation or pattern in CFR. When we look at the factors, we are basically focusing on four categories of factors. First is ability to observe social distancing. Second is health capacity, population vulnerability, and most importantly, testing. I will talk about each of these variables in detail in my later slides. So just to give you a snapshot of the results, what we find is that fatality rate in India has been declining over the month of April. And obviously, there's a lot of spatial variation across states. We also find some evidence of persistence at the state level, which means that on April 1st, states which had a high fatality rate have high fatality rates even at the end of the month. And what we find is that states which have an advantage in terms of the pre-existing conditions, which include better ability to practice social distancing, better health capacity or medical infrastructure availability, and lower proportion of vulnerable populations have lower average fatality rates. Finally, one important part of our result does focus on testing. And what we find is testing is inversely associated with fatality rate. A good thing when we were looking at testing was that we had daily data on testing. So we've not used the same sort of, we've just used very simple statistical measures over here. But for testing, we just use a very simple regression to see the association between testing rate and fatality rate. So there are two results which stand out. One is that testing has a higher effect on fatality in states which have more favorable conditions. When I say more favorable conditions, I mean these three conditions, pre-existing conditions. And finally, when what we also find is aggressive testing, which we capture as the growth in daily testing rate is more effective in the other category of states. So states which do not have an advantage to begin with. So, okay, so why study fatality? Now, as I mentioned, severity of a disease can be measured by three broad groups of measures. And we know that all three measures depend on testing rate. Now, India has been lagging behind in testing rate as compared to most of the other economies in the world. We have seen that India's testing rate has been pretty low. So it is plausible that incidence of COVID-19 in India might be underreported due to low testing. And this problem also becomes even more severe when we think about the number of asymptomatic cases. So the basic logic why we focus on death-related measures is that testing biases can hide mass cases but not mass deaths, which probably makes death-related measures more reliable. Now, when we look at death-related measures, what we find is there are two specific set of measures which are used. One is the mortality rate, and second is fatality rates. Now, in mortality rates, what you do is you just look at the proportion of total population that is dying due to a particular disease or event. The problem with this is that it does not consider the number of cases. So, if you have two groups both having 100 people in as a population, and say in the first group 2 people get infected and die, in the second group 50 people get infected but only 2 die, so that will just show as the same mortality rate. In an ongoing pandemic, probably what we want is a fatality rate which actually considers the proportion of cases that die due to a disease. Now, when we look at fatality rates, there are two specific measures used. One is the infection fatality rate, which takes the number of deaths as a ratio to the number of cases. Now, this is the measure which is widely used in the literature, but there is a problem with this measure. What this measure does is that standing today, the total cumulative deaths that have happened due to COVID divided by total number of cases standing today. But we have to keep in mind that death is a consequence of viral infection. So first the infection has to be detected and then death will be a consequence of it. So when we are considering current cases as a denominator, it might not be relevant to the number of deaths that we observe. The number of deaths today are probably more relevant to the number of cases detected in the past. As a result of which, what we do is we use this measure called case fatality rate, which is again a very simple measure, number of deaths by number of deaths plus recoveries. What happens when we replace the denominator with this is we are looking at cases which have been closed or cases which have a verdict today. So when we are actually looking at the proportion of deaths, we are more or less probably considering the same sort of populate or same sort of group which got tested or which got the infection at probably a similar timing. Obviously, there are limitations even with the case fatality rate, because underreporting and undertesting can affect death-related measures as well. But hiding mass deaths would be difficult in India. So, okay, I will not spend a lot of time on this because this is probably known to all of us. Let's look at the trend of CFR in India. So, CFR over here is plotted on the primary y-axis, and infection fatality rate is on the secondary y-axis, and we have the entire both the curves plotted for the entire month of April. What we observe is, let's focus on IFR. Now, IFR is what is widely used in newspaper reports and also probably some articles where they show that, and they call it the CFR actually. They say that the fatality rate in India is hovering around 3 to 4%, and as we can see, it is more or less stagnant, right? But if we actually look at CFR, which is the number of deaths by number of deaths plus recoveries, it has been declining since April 1st to almost the entire month, from close to 27-28% to 10%. Now, what we wanted to do next is that just check if the CFR pattern is consistent at the state level. So what we've done over here is we have a spatial map for CFR on the 1st of April and CFR on the 30th of April. Like we can see over here, there are many states which have higher CFR as compared to states which do not have, and we see a similar picture on the 30th of April. But to actually look at this more closely, we do a very simple exercise of trying to find out the persistence of CFR in India. So what we do is, as on April 1st, we group states according to their deviation from median into a high group and a low group, and we do the same for April 30th. What we find is that there is a huge number, I wouldn't say huge, but a lot of states are in the high category and low category. So as you can see, Maharashtra, Madhya Pradesh, West Bengal, Delhi, all of these had high CFRs on April 1st and continued to have high CFRs on April 30th. And states like Kerala, Tamil Nadu, Rajasthan have a low and low sort of mapping. Of course, we have some states here as well as in the other cell, but we need to look into it more carefully, because as of now, we are not being able to figure out a reason. Next, what we look at, what can be the plausible determinants that actually sort of explain the sort of a CFR pattern. Now, we've used 4 sets of category of variables over here, which we think will determine the CFR patterns in a particular state. First is the ability to practice social distancing. Now, what we're doing over here is we're using 2 measures for each of these categories to sort of capture what happens because of these variables. So for social distancing, we look at the number of urban agglomerates in a state. Obviously, if the number of urban agglomerates are higher, the probability or the chance to actually practice social distancing would be lower. Similarly, we have our proportion of households dwelling in a single room. In a particular state, which again basically captures how practical would it be for these households to practice social distancing. For health capacity, to capture the commitment of the state governments towards health spending, we look at per capita health expenditure made by states. And for medical infrastructure, we look at hospital beds per million population. Again, the third set of category that we look at is population vulnerability, depending on the reports and what we've observed in the case of other countries. We actually look at the proportion of people who are old in a particular state and the proportion of cases who have both blood pressure as well as diabetes. Finally, for testing, we've used 2 measures. One is the number of tests done by a state on a particular day per million population, and the daily growth in testing per million population. So let me just, I don't have a lot of things to show over here. What we are doing over here is we are dividing each of these variables according to whether they are above the median or below the group median into a high and low category. And then I'm looking at the average CFR for these two categories. So a number of 0.208 suggests the average CFR for states which fall in the high urban agglomerate group, and the same for low. What does this table show? This table shows that states which have a high, which do not have the flexibility of practicing social distancing, also have an average CFR higher than their counterpart. Similarly, when we come to the health capacity variables, we see that states which have low per capita health expenditure and hospital beds have a higher CFR as compared to the other category. And similarly, states which have a higher proportion of a vulnerable population group will have a higher CFR as compared to the other category. Next, we just use these two groups of high and low and just look at what is happening to the CFR over the month, because we have daily data on CFR. So as expected, we see that states with more number of agglomerates have a higher CFR throughout the month of April. Again, states with a higher proportion of households with one-room houses have a higher CFR than that of the lower than median group. Right? We see a similar picture for health capacity. So states with more per capita health expenditure and more hospital beds have a lower CFR throughout the period. And what we observe in terms of population vulnerability is very interesting. Of course, we find a similar result that more aged groups and states have a higher CFR, and similarly states with more number of COVID cases or more proportion of comorbid cases have a higher CFR, but there is some sign of convergence. Now, this means that at the fatality level, there is not much difference between the two groups. Okay, last 5 minutes of the presentation, because we had daily data on testing, what we try to see is what is happening to testing at the state level. As we can see for the overall India picture, testing has been increasing through the month. And again, there is a lot of spatial variation. We look at tests on the 15th of April. Before that, the data is sparsely available. And now over here is something very simple. We just run a simple fixed effects model. But while running this, we keep in mind that fatality of a case is conditioned on testing conducted in the past. So what we are doing is we're using testing rate, but at a lag, at a lagged level. So we use different lags over here. And we use our state fixed effects, daily fixed effects. And what we find is that testing rate is negatively associated with CFR. Finally, just the last 2 minutes of my presentation, we use so we wanted to integrate the time invariant characteristics with our regression model over here. So we use the same subsampling groups of high and low, and then try to re-estimate the regression models. What we find is that the effect of testing is higher in states that are more favorably placed, which is, again, as I mentioned earlier. But aggressive testing, which is the effect of day-on-day rise in testing rate, is higher in states that are not so favorably placed. So the main submission of this very simple work, it would be that in the absence of vaccines, testing both at levels as well as the growth can fill in the void and can turn out to be the effective tool in combating COVID-19. Yeah. So I would like to stop over here. These are just some concluding remarks, but I am sure what has been discussed in the group is far more richer than this. Thank you.
Okay, thank you very much, Ritika. So I think we can now take some questions. So if you have anything to ask, please feel free to step in or send a chat message to Amrit.
So we already have questions. Well, we already have questions from Bansi and Anirban, and actually I also have questions, but I will refrain from using my authority as the question moderator. And Bansi, go for it.
Thank you, Ritika. That was very, very interesting. So I guess I have a question, but it's partly related to, I don't know very much about the available data in India, and the little bit I've tried to find I guess I've ended up looking at sources similar to what you have. So, even in countries like the UK and in Italy and so on, in the peak of the crisis, testing rates were relatively low, and the way tests were, especially in the UK, the way tests were more or less rationed, meant that getting that denominator right was difficult, and also identifying deaths because of COVID, especially outside hospital situations, became very, very difficult. And so, in a way, we end up trusting these measures of excess deaths relative to, say, the past 5 years, which in the UK, the Office for National Statistics has been tracking. And I guess I wondered whether there's something similar available for India, or something like that could be calculated. Or is it, I imagine that formal reporting of deaths, so for death certificates, might not even be that widespread. I don't know if that data is available or how easily available it is.
Yeah, so basically, obviously, there is this problem. If deaths are not being reported, then maybe this will not be captured in this exercise. But there is one thing, like West Bengal was trying to underestimate death numbers, and then you had this interministerial committee which had gone and tried to correct it, and then West Bengal had to raise its death numbers. Also, there is some newspaper reports which talk about how the number of deaths calculated from all these, the not from hospitals but from other places like the burning huts and all, have not increased substantially. But that obviously also has, we do not know the counterfactual, like obviously because of economic.
We lost you, Ritika. Uh-oh. Oh, are you back?
Okay.
Hello?
Ritika, are you?
Can
yeah. Okay. Yes, we can hear you now.
Yeah.
Yes, please continue.
Yeah.
You were saying we don't know the counterfactual.
Yes. Yes. So we don't know the counterfactual of whether these death numbers, which we are getting from other sources, would actually be higher if there was no lockdown happening. So in that sense, yes, that is a problem. But I do not know of any other data source which would give me at a daily level what is the death coming in. I do not know. I'll have to look into it.
Okay. So Anirban, you have a question?
Yes. So this is very interesting, and since we're talking about testing, so I mean testing, and you mentioned the case of West Bengal. I think one of the criticisms is that there's been very low testing in West Bengal. So clearly, testing is something in the hands of the state governments, right? So wouldn't it be interesting to look at the determinants of testing?
Right.
I mean, it's not just a constraint, not just a technological constraint. I mean,
right. So obviously we have the ICMR guidelines to go about as to how to practice, what are the type of tests, or who are the people who should be targeted for testing. But at the same time, like we can see, there's a lot of variation on how different states are implementing it. So obviously that is something that we can really look at. Yeah. Thank you.
Okay. So we have a question from Rohini on testing, and then to Shailendra.
Right.
Rohini?
Yeah. No, Ritika, just to relate it to what I was saying earlier, that if the center is declaring zones, then states will have really no incentive to test, because if you test at high rates, and that means that you're going to be declared a red zone. So I just wanted to point out the incentive problem there.
Okay.
Yes, next. Yeah. Go for it.
Yeah. Hi, this is Shailendra. Quick question, Ritika. So your estimates that you showed, I want to understand exactly what those point estimates mean. I thought I saw 13.7. So is that like in percent for change? So for a 10% increase in testing, you have, I'm just trying to understand those numbers.
Okay, 1 second. Right. So, yeah. So basically, for a 10% increase in testing, the fatality rate would reduce by 13%.
Okay.
Right.
Okay, and then another question I had, and this is more from anecdotal evidence.
Right.
Talk to sort of parents who've actually gone in for testing, in Chennai, and these are old people, and just the sheer anxiety of that, because it's a long wait, 2 or 3 days before you get to know the results. Is there any evidence at all about how this heightened stress has affected mortality, especially for people with heart disease, underlying conditions?
Yeah. So I know from newspaper reports that yes, it is affecting them, but in terms of incorporating it in my analysis, I don't know how to do it, because in terms of when it comes to using the data on population vulnerability, or even for that matter variables like social ability to social distance, or socially distance, or uh, health capacity, all of these are predetermined variables which I get at an annual level. So these are not probably tracking the ongoing population vulnerability. So these are slightly outdated, but yes, I do not know how to integrate it into this particular analysis, but yeah, point
No,
taken.
that's fine. That's fine. I mean, I was not expecting that. I mean, it's more like from other countries, do we have any evidence? But it sounds like there's not much at this point.
Okay.
So let's have one last question from Parikit, and then move on to the next.
Okay, Ritika, I noticed in some of your graphs that the fatality rates are different across different groups. For example, congested states versus less congested states.
Right.
But there's some sort of convergence. So
Yes.
it's narrowing over time. And I've seen it in graphs that others have reproduced. You see huge cross-sectional variations, but as time passes, things converge. And especially for the fatality rate, for example, congestion and one-room houses, they will certainly affect the infection rates on a, and that can be expected to persist. But conditional on falling sick, and given that this is no treatment, one would imagine that the fatality rates, the true underlying fatality rates, won't be much different. So my question is, do you see this convergence in the fatality rates? Is that a sort of robust feature that you're seeing, that the gaps are narrowing over time across these binary groups? And secondly, if that is true, couldn't you use some sort of extrapolation methods to find, where they're converging, so that we have a sense of, what the true underlying fatality rates are?
Right. Right. So basically, what we see is that I'll just share the screen once more to show the graph. Yeah. Can you see it? Can you see my presentation?
Not yet.
Not yet.
Oh, I'm so sorry. 1 second.
Now it's visible. Yeah.
Anyway. Oh yeah. Okay.
Yeah, it's visible.
So. So we see a very strong sign of convergence when we look at the population vulnerability groups of high and low. Not so much as of now, but of course here also we can say that over time probably they will converge. So what we intend to do is, because it is only done for the month of April, we intend to extend it to May once we have more data, and then we are also planning to extend this entire exercise at the district level, which will probably give us a better picture on what is happening inside the states. So as of now, we know that there is something which is affecting both the groups, at least for population vulnerability, and the two rates are converging, but we do not have an answer. We do not have a very concrete answer as to why. Maybe some factor which will come up in our district level analysis.
Thanks very much, Zaki.
Okay.
Thank you.